This is a follow-on from a presentation I gave at the Procon panel at the 2020 International E-Congress hosted by Ezra Nazra. The link to the video of that presentation is in the description below. I was privileged to share the panel with three fantastic speakers and experts, Nadia Hernandez, Jeff Gadsden, and Anahi Perlis. And what follows here is a short summary of the main points that I personally took away from our discussion, and also supplemented by some other excellent presentations at the Congress. The first thing to make clear is that there is, despite Jeff Gadsden's cheeky comment about the ESP block, there is no one block to rule them all. Every block has its advantages and limitations. Borrowing again from Jeff's presentation, the analogy of a regional anesthesia toolbox is a good one. Ideally, we would all have an extensive toolbox, allowing us to pick and choose the optimal tool for the job ahead of us. If you need to put in nails, a hammer is best. But we may not all possess or have access to a big toolbox, so having your own Swiss Army knife is a good idea, especially where a hammer is overkill or inappropriate. Think thoracic epidurals. And at other times, when you're in a tight spot and you have nothing else to use. Everyone, however, wants to know, what's the best block to do for abdominal surgery? Unfortunately, the answer, like much of life, is that it depends. Life in the practice of medicine is not like a game of chess, in which outcomes are governed by defined rules and strategies. Instead, it's more like a game of poker, which consists of making decisions in the face of uncertainty. Probabilistic thinking is what is needed. We have to weigh pros and cons, or in the case of regional anesthesia interventions, balance the potential benefits versus potential adverse effects without ever being quite sure which we are going to see. The quality of decision making is unfortunately not always going to be reflected in the observed outcome. Prof. Narinder Rawal, in an excellent prospect panel discussion at the E-Congress, highlighted the fact that one of the problems in clinical decision making is that the evidence base for efficacy is often much larger and more robust than the evidence base for adverse effects and complications. Adverse effects are just that much harder to measure, in large part because they're fortunately quite rare, especially in regional anesthesia. However, what this means is that it's easy to overestimate or underestimate risks depending on your personal bias. And this will often show up in debates when proponents of a technique will focus purely on the efficacy of the technique, while the opponents will focus on the risks associated with that technique. It's worth noting that thoracic epidurals have a long history behind them, and the evidence base for their efficacy is well established. Abdominal wall blocks are relatively new and under-investigated, and so while they're probably safer from a theoretical point of view, at this stage, what we don't know is whether they have benefits beyond the reduction seen in 24-hour pain scores and opiate consumption, whether they actually impact other patient-centered outcomes of recovery, and whether these benefits are going to be seen over longer time periods. Striking a balance or compromise between potential benefits and risks must be taken in the context of the individual patient's surgery and setting. And here are some considerations to illustrate these, but note that these are not exhaustive and not absolute. In general, though, thoracic epidurals are probably better suited to surgery that involves large open incisions, especially those in the upper abdomen and those that extend across the midline. Much is made of the possible effect on visceral analgesia, but I'm not sure whether visceral pain is as big a problem as we make it out to be. Pain from abdominal viscera is usually in response to distension of hollow viscera or an inflammatory response, not so much cutting and burning of tissues. What may be more important is that the sympathetic blockade of thoracic epidurals improves splanchnic perfusion and gut microcirculation, which may aid immune function and healing. There are going to be patients who will stand to gain much more benefit from thoracic epidurals, for example those at high risk of respiratory complications where thoracic epidurals have clearly been shown to reduce this risk. I think at this time, properly working thoracic epidurals also have an edge in providing better analgesia, so they may be preferred in patients with chronic pain or who are opioid habituated. Thoracic epidurals are also by definition a continuous regional anesthesia technique, and they're readily maintained for 48 to 72 hours. Whereas at this time, abdominal wall blocks are more commonly performed as single injection techniques, with effects that rarely last more than 8 to 12 hours. Having said that, abdominal wall blocks are a logical choice when challenges or contraindications to thoracic epidural placement exist. Finally, we have to consider our personal limitations and that of the setting in which we practice. We have to be confident of executing the block without harm to the patient and with a good chance of success. And particularly for epidurals, we have to be sure that the necessary framework is in place to manage the epidural in the postoperative phase. There has to be buy-in from the colleagues that we work with. As I said during the debate, thoracic epidurals don't have to be as hard as we make them out to be. Speaking as someone who now practices where thoracic epidurals are only occasionally inserted, I would recommend the following modifications to the traditional method. First, use ultrasound to locate the interlaminar space and level, as described in my YouTube video. Second, ensure that you adopt an appropriate insertion point and trajectory. This means staying medial and close to the midline, just alongside the spinous process, and keeping that lateral to medial angle small. Needle entry is readily confirmed by feel of the ligamentum flavum, which is usually honed by residency training in the labor and delivery suite. And I usually look for the loss of resistance to saline or air, preferring saline. Finally, use epidural stimulation or waveform analysis, or even both, to confirm catheter placement in the epidural space and that the tip is in at an appropriate level. Now, a point that was acknowledged in our discussion is that not all abdominal wall blocks are always that easy to perform either. There is also the dilemma of choice. I will offer up some very general personal opinions regarding choice, which are similar to what Jeff Gadsden suggested in his talk. For surgery in the lower abdomen, the lateral tap block and the similar variants are a good choice. They're easy, simple, and work fairly well. The quadratus lumborum block is another alternative in lower abdominal surgery. Now, some variants are touted to cover the upper abdomen as well, but I think we need more evidence before I would be comfortable standing by this. Like Jeff, I do believe the rectus sheath block is an excellent first choice in midline incisions. It can easily be done postoperatively and lends itself well to bilateral catheter techniques. And of course, we have the erector spinae plane block, which can be targeted to cover the upper or lower abdomen as desired. Here, the evidence is definitely promising, but more research is needed to confirm the early findings. So the purpose of this video was not to give you definitive answers, but really to provoke thought and discussion. I would say at this time both thoracic epidurals and abdominal wall blocks are valuable techniques. As thoracic epidurals are less and less often performed, I do think we need to take advantage of the technical aids that are available to help us perform them, such as epidural stimulation and waveform analysis, and to routinely incorporate this into the education of our trainees. Postoperative management is a separate issue to be tackled, but it's one that can be addressed with good interdisciplinary teamwork. At the same time, abdominal wall blocks are here to stay and they have their place in certain contexts. I think it will be helpful to identify the few core techniques that are most useful, and we'll need to continue with high-quality clinical research into these blocks, focusing on patient-centered outcomes beyond just moderate reductions in pain scores and opioid consumption.